Good afternoon and welcome to this webinar on the Mercy Health Addiction Treatment Collaborative. I'm David Collins, a member of the Training, TA, and Evaluation team. And as Wally had said, if you have not already done so, please type in your first and last name and the county in the chat bar. Please include your email address to get a copy of the presentation from today. Today's presentation will last about 15 minutes. And during this time, we ask everyone to stay muted so that we can minimize any background noise.
So there is
and then follow.
You can do it since the offer audio access.
And then following the presentation, we will have questions and answers until the end of the webinar. So please feel free to type your questions in the chat box or unmute your phone to ask your question. And this webinar is being recorded and will be posted to the CCIM4C website.
Thanks, David. So the Community Collective Impact Model for Change is an initiative that's funded under the Federal 21st Century Cure Act. Through the 21st Century Cures Act, Ohio MOS awarded funding to 12 Ohio communities who are strategizing to address opioid use and misuse through an intensive strategic planning process with implementation starting to begin in the next few months. Ohio MOS has partnered with Ohio University, PIRE, the Pacific Institute for Research Evaluation, and Prevention Institute to develop training and technical assistance, leadership development, and evaluation services for the 12 communities. Overall, the goal of the 21st Century Cure Act here in Ohio is to prevent opioid use and abuse, reduce opioid-related deaths, and increase access to treatment, including medication-assisted treatment. We have a wonderful website, and so be sure to check that out at the conclusion of the webinar. A little bit about the webinar series. We hope to bring together those in the field to share their successes, lessons learned, and their experiences with others, and also to provide additional resources for not only our CCIM4C communities, but also their partners and those who are working across the state of Ohio and maybe the nation to address opioid use and misuse. So without further ado, I would like to introduce Dr. Kang and Dr. Graham from Mercy Health, and they're going to talk to us about the Mercy Health Addiction Treatment Collaborative. Dr. Kang, you're also a presenter, so you should be able to advance your slides with the arrow.
Okay, great. This is Nav Kang. Actually, Dr. Graham was not able to join us today in a conflict that came up at the last minute, so you'll just have me today. We'll have about 15 minutes to go through the presentation, so I'm going to move rather quickly, and then we'll have question and answer time till the end, as David mentioned earlier. As you can see, I'm a psychologist by training and director of operations for behavioral health for Mercy in Cincinnati. We're going to go through a few primary areas. I want to talk about our comprehensive response to the opiate epidemic. I'm going to fly through that piece particularly quickly, and then I'm going to focus on the addiction treatment collaborative piece because that's probably more relevant to the group when we're talking about collaboration and a backbone organization. We are not actually grant recipients from CCIM4C, but I think the way that we've done things is relevant to the groups, and that's why we were asked to present. So just to give a little bit of background, this slide is actually already outdated because Mercy Health has merged with Bon Secours Health System, a 20-hospital system on the East Coast, and so we've formed a new organization called Bon Secours Mercy Health, but this is a legacy Mercy Health footprint. We are the largest health system in the state of Ohio and the largest health system in Cincinnati, which is specifically the community where we're going to talk about the Addiction Treatment Collaborative. To give you a little bit of context, and obviously I think everyone knows that Ohio is a Medicaid expansion state, 5 managed payers. To give you a little bit of context for Cincinnati specifically, if you aren't aware of how healthcare works in Cincinnati, we have a number of different health systems. So if you count the Northern Kentucky system and the Children's system here we have 6 large health systems just in Cincinnati proper, with Dayton very close by. When it comes to Mercy in Cincinnati, we have 5 acute care hospitals with emergency departments in them, and then 4 freestanding EDs, and then dozens of ambulatory care locations across the city as well. We'll talk a little bit about our addiction treatment services, but historically we really haven't operated in that space, much like many large health systems. So again, I'm going to fly through some of this stuff. Most folks here are probably familiar with the scope of the problem that we're dealing with. This is a little outdated data, but it's the most simple slide that we can use to kind of depict the scope of the problem. So this is 2016 data. This is an estimate slide from summer of 17 for 2016. Everyone probably knows the actual year-end data for 2016 was that 63,600 Americans died from drug overdoses. 2/3 of those involved opioids, and it's a 21% increase from the prior year in 2015. You can see the relative numbers when it comes to peak car crash, HIV, and gun deaths. So an epidemic the likes of which we've never seen before. Certainly the HIV of our times, or the public health crisis of our times. Over the last couple of weeks, there's been a lot of media around the 2017 estimate numbers, not just nationally, but specifically in the state of Ohio. And so the numbers for 2017 certainly don't look good. We actually have some preliminary 2018 data, which is a bit encouraging for the work that we're doing in Cincinnati, which I'll share at the end of the presentation. So to give a little bit of context, I mean, Mercy is, again, a large multi-specialty hospital system. And so we serve as the backbone organization in our community for an addiction treatment collaborative. We would not have been able to do essentially anything that we have done when it comes to our clinical protocols or community collaboration without leadership support. So this slide is in here to talk about how important it is to have leadership buy-in, really when you're going to do anything, but especially when you're going to do something that is not just one paradigm shift, but perhaps a series of paradigm shifts, one after the other. And so the Mercy Health Board adopted the strategic initiative, which is another way of saying that executive compensation has been tied for the last 2 years to our response in this space. Now, not everything that I'm going to talk about informs executive compensation, but if the organization literally puts their money where their mouth is, and you end up getting more support from a variety of different areas to be able to get things done. And so having that leadership support was certainly transformative to our work over the last 2 years in particular. We've been doing much of this since January of 16 in various parts of the state, but specifically to really launch it and take it to scale, this has been tremendously helpful. So our comprehensive response has 4 main pillars to it. The one that's emphasized, treating those in need, that's what I'm going to talk mostly about today, but I'm going to fly through the other pieces. So like many health systems, we do quite a bit in terms of prevention, preventing entry into the space through education to younger folks, through our school-based partnerships, but then also medication-safe drop boxes or the use of Deterra packets in post-op patients, changing our order sets on the inpatient service to remove opiates and to prioritize non-opiate pain management options. Each of these could be talked about in its own webinar or in its own presentation, but I'm just referencing them here so that folks are generally aware. PDMP integration and monitoring of prescribing practices, those kinds of things. And again, I think most large health systems nowadays, especially in states like Ohio, are already doing. So some of the foundational kind of stuff. Screening is critically important. The RT in SBIRT is oftentimes the most challenging piece. How do you actually refer someone to treatment? If historically the wait time to get into addiction medicine in Hamilton County, which is the county where Cincinnati resides, is historically 53 days, how can you make an effective referral? That has historically always been a challenge for us, and so we sought to do something different in that space, which again I'm going to get to as we talk about the addiction treatment collaborative. As I mentioned already, PDMP integration and prescriber monitoring and talking with physicians about their prescribing practices, both within specialty and as compared to the general provider population. So when you have that specialty-specific conversation, that can eliminate some folks who say, well, I work in this specialty and my patients are therefore different, and so my prescribing needs to look different. If someone is an outlier within their specialty or their subspecialties, and it's hard for that argument to hold water. But again, when you're looking at accounting for the variance of current patients who have a use disorder, like if the federal government estimates 626,000 Americans with heroin-associated opioid use disorder, 2.1 million with OUD in general, which could actually be up to 5 million. This kind of stuff is not necessarily helpful to those who currently have the condition. And so treating those in need really was where we wanted to focus our energy. Part of that is harm reduction, so Narcan distribution and VBP programs like a needle exchange. I think what we did that was kind of unique is to place the syringe exchange vans on our hospital grounds so that we look at it as part of the healthcare continuum. And again, probably preaching to the choir here, but a syringe exchange is more than the transaction. In addition to creating an economy for used syringes to get them out of the community, out of playgrounds and parking lots, it is also about the compassionate conversation that happens about getting into treatment, getting into recovery. So let's talk about treating those in need and the formation of the Addiction Treatment Collaborative. Again, this work has been going on for a few years at a small scale, but then taken to a major metropolitan area in Cincinnati, Ohio, over the course of 2017, which we'll talk about. Frankly, starting this work, we really had to educate ourselves. Hopefully everyone here is aware of and has read the 2016 Surgeon General's report. This is just a picture of the cover. If you have not, it's a tremendous way to become thoroughly well-versed in essentially everything regarding addiction in our country. It is essentially a textbook that provides one of the most tremendous literature reviews on the topic that you can find. It's a great way to get started. And that's what we used to understand what the then disintegrated continuum of care looked like. The parts I put in bold on this slide are the services that we own and operate. So again, we have hospitals, emergency rooms, primary care. The pieces that are not in bold are the addiction medicine services that we do not offer as a system. And frankly, didn't know who all was out there doing this work and who was doing it well. And so that was one of the reasons that even within behavioral health, we didn't have a great understanding of who all the players were on the field, and much less how to access their services and access them in a robust kind of way. So part of this was really just finding out who is out there and what kind of work are they doing. I'm going to skip over a few slides here in the interest of time, but the emphasis point on this and slides like it is that one of the things that we have sought to espouse internally and externally in the community is the notion of addiction as a chronic disease. So the moral failing argument, we do what we can to challenge that argument, to have folks grapple with that. Similarly with harm reduction around Narcan distribution, we have folks grapple with the moral hazard argument that people tend to bring up with that. And really look at the comprehensive healthcare response. If we look at addiction as a chronic disease, then we should treat it like we do with the way that we treat every other chronic disease, and that is thoroughly, like from point of entry into healthcare to the entire care episode to transitions of care and essentially everything. You should be able to take the use disorder out and replace it with diabetes or a cardiac condition, and everything about the treatment functionally should be very similar, if not exactly the same. So we had this question on the table for a while about should we build a bunch of addiction treatment centers? Again, the wait times were so bad that we thought that there is really no answer in the community already, so we would literally have to build it, which would take time and have quite a bit of learning involved in terms of regulations and whatnot. We did have this theory that what if we could collaborate with those who are already doing the work? We, again, had been doing that at very small scale, at like a small county level, so one hospital, one addiction treatment center, et cetera. But could we take it to scale? Could we leverage a shared capacity at the community level to create treatment on demand? Question. And either way, if that works, we really have a great opportunity then to redefine what we do as a hospital system and how we participate in the continuum of addiction treatment services, because we shouldn't do nothing. So briefly, this goes through like a bit of a timeline to take the plans to scale over the course of last summer. So very scientifically, we did a Google search to find who are the addiction medicine providers in Cincinnati. We came up with a list of about 24 groups. We sent them a request for information supported by our legal department, so it was a legal document. But basically, we just asked two questions. One is, are you interested in collaborating with Mercy in this space? And second, if you are, then who is your medical director? Our thinking being that these folks are competitors, they may not want to talk to each other, but if we put clinicians at the front of the discussion, then they're likely to keep patients at the center of their decision-making and the center of our action. So our thinking was we would have a monthly medical directors meeting, which has actually continued since last year, and we meet monthly. We share data, we share best practices. There is a dashboard that the group submits to me. I collate it and we look at it together to talk about what's our access look like and what are our clinical outcomes. So amazingly, we had originally 27 outcome metrics or KPIs, however you want to think about that. And as a group of 15 organizations, we have it boiled down to 2 that everyone has agreed serve as solid metrics of what we're seeking to do. Each of the 2 metrics has 3 sub-metrics to it. Actually, a total of 6, but there's variations on it. And so over the course of 2018, what we thought was, in parallel in 2017, while building the community collaborative, we also developed our clinical protocols for the hospital site. So, for example, elective withdrawal management, acute withdrawal management for alcohol and for opiates. How would we do that? What would that look like? Another example in the ED setting, buprenorphine administration in the ED. When do you do that? When do you not do that? When do you instead choose to prescribe a patient a withdrawal management pack of comfort medication? So those dispositional decisions and how do we actually stand this up, some of the nursing training and education and social work training and that kind of thing. We did that in parallel in 2017, but didn't actually launch it. So at that point, it was more developing the protocols as opposed to launching them. 2018 has actually been about launching those protocols and participating in the treatment continuum. The reason being that, especially for opioid use disorder, with opiates, if you do elective detox or inpatient acute withdrawal management, then you reduce someone's tolerance, and if you send them out without a place for them to go and continue treatment immediately, that is unsafe, but it's also borderline unethical. So what we knew that we needed first was treatment on demand, and then we could stand up our hospital-based protocol. So both of these things were really a 1A and a 1B, but the primary was to form treatment on demand first, to get these groups together and say, who's holding wait lists? Well, let's stop doing that because wait lists are frankly death lists. And what we need to do is understand each other's capability, and when there's a patient that's in need, we ensure that they get immediate access to care. So it's pretty cool to see this kind of thing materialize very quickly. Frankly, out of the gate, we were concerned that no one would even come to talk to us, but as it turned out, folks were willing to work together and to say, I have this patient, I can't meet their need for whatever reason, whether it's I don't have the capability or we have a wait list, and someone served them, and literally within hours you would see that need being responded to and someone else picking up the patient and running with them. So a true collaboration, genuine spirit of collaboration being at the core of it, knowing that unfortunately there's plenty of work for everyone to do. And it's really about helping people access that. So what we have distilled down is these 3 elements. We look at these as being replicable elements. There's probably different ways that each of the elements could be stood up in any community, but our theory has been that any community can do all of these. So Narcan distribution and availability, yes. Community conversations around the controversial nature of Narcan. Those things need to happen. Those thoughts and fears and concerns need to be heard and validated, and then also married with education. But as a health system, our official stance can be very straightforward and frankly simple, that Narcan saves lives. And so we support the distribution and availability of Narcan financially. We supported the Narcan distribution collaborative in Hamilton County, which has been in the process of where it's not finished yet, should be by the end of the year, and then renewed for 2019, in distributing 30,000 doses of Narcan across the community, across Southwest Ohio, not just Hamilton County. Treatment on demand is essential, so you save a life and immediately have a conversation with the person. Hey man, you just died. If you want to get into treatment, we can get started right now. That answer has to be there, immediately available. And so treatment on demand literally means same or next day availability to see a prescriber to initiate treatment. It could be for other use disorders as well. Obviously, the motivation being the salient variable, that when that motivation is there, we have to capitalize on it. We have to give people an answer when they're ready to get into recovery to get started now. Because if you miss the opportunity, in many cases, you might not have that opportunity again. And then the integration of the health system is important. So a small percentage of folks will actually need inpatient services. A small percentage of folks will actually meet criteria to be admitted to inpatient for opiate withdrawal. Most actually, when they're admitted for inpatient, are going to be needing alcohol withdrawal. But either way, the ERs are 24/7 operations that assist with the treatment on demand aspect to it. Oftentimes, folks also have other clinical needs that an addiction treatment provider simply can't provide. Just like any other specialist, they're able to do their specialty, but then they need help either from primary care or another specialist in order to manage the patient's complete set of needs. And so health system integration being the third element to round out what the continuum looks like, to round out treatment on demand, and to ultimately meet all of the patient's needs. We look at this, if delivered compassionately at a community level, it can really start to change the narrative around how people see use disorders, how people view addiction. To give you a little insight into what is in our signed agreements that we have with these 14 addiction treatment providers across the community, it's this notion of everyone using your best reasonable efforts to accept patients into your care. We have given access to the addiction treatment providers to our clinically integrated network of employed and affiliate providers. So very literally, any provider can just look up any other provider through the Perfect Serve application on their phone and have a conversation with them. It's a pretty cool thing to be able to have provider-to-provider communication, talk about any patient need that you share. The remote access to Epic is a pretty interesting thing. So we had this theory very early in the process, a couple years old at this point, but if an addiction treatment provider routinely needs an hour to see the patient for their first visit, do the H&P and everything else, if they had access to our record, if the patient was in the ER and we just did an H&P, or if the patient was an inpatient and we just did an H&P and labs and medication record and everything else, could they truncate their initial visit and have it be less than an hour? And the theory did pan out, and so on average, we're talking about truncating that initial visit from 60 minutes down to 25, which artificially enhances the addiction treatment provider's capacity. In the same hour they could normally just see one patient, they can now see two. So a pretty cool thing to be able to together raise the access in the community. Wasn't something we anticipated at the beginning, but certainly worked out and continues to. So one of the things that I referenced earlier, again, is our internal capability. So we formed a clinical work group within our health system to define what our capability should look like, to help standardize what our care would look like across sites, across different levels of care, ER, hospital medicine, et cetera. And it's actually written in a clinical practice guideline. What we found as we had those conversations was that we have a lot of bias within our system. And so we had to own that. We got some quotes in here from folks about, like this one here is specifically an ED provider talking about operationalizing the 3-day rule, right? So I'll administer buprenorphine today, but not tomorrow or the next day. We don't tend to talk about medication administration or continuation like that with other conditions. So if a patient is admitted who is already receiving opioid replacement therapy, we had providers who would say, I'm not going to continue their buprenorphine, I'll continue everything else. We don't have that same problem with insulin. And so a lot of challenging dialogue, a lot of great conversations came out of this. A couple of quotes here around needing to prove that you're motivated. Well, we don't ask the patient who's walking into the hospital or being brought into the hospital in DKA after eating a dozen donuts to prove that they're motivated to be treated. We just treat them. EMS does not go to the patient's house who is calling for COPD exacerbation because they're in distress, but then tell the patient, we're not going to take you to the hospital because when we got here, you were sitting there smoking a cigarette. So some of these conversations in the community were very fruitful. They were very instructive, and I think they shed a lot of light, not on the content as much as the feelings that a lot of us have as healthcare providers around patient motivation or the lack thereof, or how do we get people to do something that they might be ambivalent about. And ironically, as humans, we are all ambivalent about change. And so navigating that challenge together has been guidelines boil down to really one central tenet, and that is that if we stand up our services the way that we're talking about, we will likely initiate treatment, and a collaborating organization would continue treatment. And we can initiate treatment in a variety of ways, as I briefly referenced earlier, but then a collaborator would continue treatment, and then we would coordinate care and work together on whatever other needs that a patient has. Visual depiction here kind of tells you the directionality. One important element is that if an addiction treatment provider who does ambulatory detox and other services ends up encountering a patient need that they can't meet, whether it's an addiction treatment need or it is some other need, do they have the ability to rapidly access hospital services? Yes, that is part of our clinical practice guideline. This was a guideline that was initially drafted internally, but then ended up being expanded upon and revised with input from all 14 other organizations. So it is truly an interprofessional, interagency clinical practice guideline, which is pretty remarkable. One of the challenges that we found, I'll be very quick with this because I know I'm kind of over my 15 minutes talking time, is that as clinicians, we didn't anticipate this problem, but we probably should have predicted into it, is that you can create treatment on demand, which we, again, have in Cincinnati, Ohio today. But building public awareness of it, or even clinical awareness of it within the clinical population, is not the easiest thing to do. So Mercy Health Foundation funded the startup of findlocaltreatment.com, which is a website. And as you can see, it's not an app. It doesn't require download. It doesn't require update. You can look at it from any web-enabled device. Everyone on the phone can pull it up on your computer now. I've got some old images of it. It's been significantly updated since these screenshots were pulled. But effectively, you can put in whatever amount of demographic information that you want, and it will let you know who is accepting new patients now. And so the updates to this platform since it launched in May of 2018, just a few months ago, have been fast and furious. We have a number of providers that are on the platform. It allows you to book assessments through the site. It gives you a great amount of information in terms of who does walk-ins, who does phone hours, 24/7 scheduling, all of this kind of stuff. And so one of the things we sought to solve from the beginning was the Saturday at midnight problem, or the Friday at midnight problem. The patient walks in, addiction medicine isn't open until Monday morning. You can give that patient an intake now. You can initiate treatment from the hospital, again, in the ways that I talked about before, and that patient can seamlessly go to next level of care. So patient navigation has been a huge piece. The platform allows us to see where people are searching for treatment. So men are searching for alcohol treatment on the west side of town. Women are searching for opiate treatment on the east side. Any kind of permutation of that kind of thing that we're talking about. Queuing analysis proves out that most people are searching for treatment after addiction treatment providers are closed. And so again, that speaks to why health system integration, ER standardization, that kind of stuff is necessary. The capacity that's out there in the community is also a salient variable to highlight, that there, again, remains treatment on demand, even as we have more people entering the treatment stage. So through May of this year, and actually just a couple of days ago, the June year-to-date data was released by Hamilton County Public Health, which mirrors these results very closely. We had a massive influx of Narcan into the community, and so a lot of people then would say, okay, sure, you're saving lives, the 34% decrease in overdose deaths, the mortality bed, but you're probably just going out and reviving the same people over and over and over again. The next two data points actually refute that argument. So a 33% decrease in EMS runs 6 months over 6 months, and then the 36% decrease in overdose visits to ERs. Point D is not necessarily a great thing, because if there's more fentanyl in the community, you probably want more people to go to the ERs to be monitored. And so a phantom variable in there is that people oftentimes opt out of going. But if you use findlocaltreatment.com and educate EMS, they can have a different conversation with the person aside from just Narcanning them and walking away. If that person wants to get into recovery, that EMS personnel can schedule them with an appointment, give them resources to get connected, whatever the person's interest is in that moment. That doesn't have to include going to the hospital, which is obviously the recommendation so that patients can be monitored and everything. But if someone's refusing that, there's at least other options that they have to give. And really the final variable here, the tremendous increase of people entering treatment has been the thing. So it linearly plays out. You use Narcan to save a life. That life is saved, but then you have conversation about entering into recovery and capitalizing on treatment on demand. So initial data for sure, and yes, this is pre-peak, pre-2017, really is what we've returned to, but progress is progress. It does make us hopeful that we can sustain this through 2018 and then continue into the future. The University of Cincinnati is crunching some of the initial data, and so what we're seeing is there is a hypothesis. If you were to flood the market with Narcan, as point A indicates here, you should have a mortality bend. However, the mortality bend that we've seen is statistically significantly more profound than what you would have anticipated just with the Narcan distribution, which again speaks to treatment on demand and health system integration as being necessary element. Quick slide on some of the other stuff that we have to do. Point D, I'm going to highlight that one just in case that one is more difficult to understand. But in the HIV epidemic, there were a couple of things that really turned the narrative. So one was the Ryan-White Act, so legislation. And what's in front of Congress right now is a starting place, but frankly, there is more impactful work that needs to be done in terms of actual access to care. But the other was Magic Johnson. So stigma and bias and the cognitive dissonance that he produced by telling his story. So people have had to struggle and grapple with the idea that how can this person, who I admire and revere, be guilty of some type of moral failing. And that really caused people to have a different type of dialogue around HIV. And yes, we have a lot of folks who are in recovery, and some of them are local celebrities, but we really need someone who can speak to this at the national level, someone in recovery themselves. And we would seek to identify who that person is, in addition to all the other things we're talking about. So our contact information is here. Dr. Graham and I are happy to take any questions through email after today's webinar. That's our last slide, and I'm happy to do question and answer until the end of our time, if we haven't passed it already.
Well, Dr. King, thank you so much. This was exactly the right information at the right time for our CCIM4C communities. I'm just going to open up real quickly to see if anyone has any questions, because I do know we're over time. We have a lot of people who are just joined us by phone, so I want to give that opportunity. Remember, if you join us by phone, please make sure you unmute. I see a question coming up from Molly Stevens. She's in Lawrence County, so out your way, Dr. King.
We're typing a question.
Oh, do you just want to go ahead and say it?
Yeah, we're on the edge of our seat. You could just ask.
Okay. With the recent merger of Bon Secours and Mercy, we have Bon Secours just in our area. We're in the Southern Ohio, Ashland, Kentucky,
Sure.
and Huntington Market. Is there a chance that this treatment near me will be opened up to this area, to expand to this area, that we would be able to have access to that for our community?
So you're talking about findlocaltreatment.com, the website?
Yes.
The next community so that's actually a separate organization from Mercy. We actually don't have any equity stake in them or any ownership or anything like that. We do work closely to identify communities that have a need. So there's two answers to the question. One is the next city or the next area that we're looking at intentionally expanding the site to is Toledo, Ohio. That being said, if you go to the site and scroll down just a little bit from the first initial demographic entry page, just scroll down a little bit on the main page, and it'll give you the option to say, like, we are a treatment provider, or we want our community listed on the platform. How can we do that? Because the idea is to take it to any communities that are interested in providing a gateway to treatment on demand. You kind of need to have treatment available in order for it to be ultimately useful or helpful. But,
right.
But certainly, the folks who have built the platform and continue to expand on it want to expand the platform to any communities that are interested. So.
Okay, so it doesn't have to be a Bon Secours initiated.
Correct. It can come from anywhere.
Okay.
So there are some conversations that are happening with treatment providers and healthcare providers in Dallas, as an Fort Mercy Health has nothing to do with Texas or Dallas or anything like that.
Right, okay. Okay, thank you.
Sure.
Do we have any other questions before we close out and we get people on their way for the afternoon? All right. On behalf of
Well,
our.
please feel free to reach out to us, everybody. You know, again, we're pretty responsive through email, and when we write back, our cell phone information will be in there as well. We usually share that. I should have put it on the slide, but happy to collaborate in any way. Everything we've created is open door, open source, so happy to share everything.
What was the website again? I'm sorry.
FindALocalTreatment.com.
FindALocalTreatment.com. Okay.
Find the local treatment, FLT, FindLocalTreatment.com.
Oh, okay. Thank you.
Here. You can access from your phone, from your tablet, from your PC, etc.
Oh, we have one more typing in, Dr. Payne. Oh.
Okay.
Looks like they went away. All right. Thank you, everybody. Again, Dr. Payne, we really appreciate your time today, and everyone have a good rest of your afternoon. Thank you.
Thanks for the opportunity, everyone.
All right.
Good day.
This concludes our webinar. Bye-bye.